So with that said, we can still get a lot out of this question and answer type format here. Let's start with this one. You have chronic bloody diarrhea in a young adult. The disease is associated with skip lesions, the string sign, creeping fat. You can get fistula formation, and it is ASCA positive. That's describing Crohn's disease. And if we look at our inflammatory bowel disease lecture, this was our last lecture actually, you can see that you can get diarrhea. It can be bloody or non-bloody. They tend to have it be bloody more often than not. And here we have some features that are specific to Crohn's disease, like the string sign, your creeping fat. You have several different complications. So know the differences between Crohn's and UC when a question like this comes up, because that's usually what they're going to be testing you on. So what happens if you find somebody a chronic bloody diarrhea in a young adult again, but this disease now is associated with continuous lesions, it's P-ANCA positive, you have a risk of colon cancer or primary sclerosing cholangitis, you can see pseudopolyps or crypt abscesses. So now we're describing UC, and here are some features specific to UC that you need to be aware of. Again, think about that lead pipe sign, all these complications. So know the difference between Crohn's and UC for sure. What if you find somebody with chronic bloody diarrhea, fever, right upper quadrant abdominal pain, jaundice, and fatigue? They might mention onion skin fibrosis on a biopsy or a beads on a string appearance on a cholangiography. So now we're talking about primary sclerosing cholangitis, which is a potential complication of UC. So again, here's PSC. I talked about it a little bit in the UC section. You're going to see it as its own condition in the hepatobiliary unit. And notice that in addition to your ulcerative colitis or IBD symptoms, these bloody diarrhea, abdominal pain, and fever, in addition to that, you're going to see right upper quadrant abdominal pain, jaundice. So you're going to see some sort of biliary disease as well. And here you can see the onion skin fibrosis and the beating of the ducts. And I talk about that. I show pictures of both of those in the hepatobiliary unit if you want to learn more about PSC. What if you find a middle-aged female with diarrhea and abdominal pain associated with defecation? If you do any laboratory studies or colonoscopy, everything's negative, and this is often diagnosed by the Rome criteria. So now we're describing irritable bowel syndrome, or IBS. And here we go with IBS. I just wanted to point out in the setting of chronic diarrhea that we're talking about, you can get diarrhea. So IBS-D would be diarrhea predominant IBS, and that's kind of what we're referring to here. And here's your Rome criteria. Always remember, they're going to mention this sort of pain related to defecation if they want you to pick IBS on a question stem of an individual with chronic diarrhea. So now, what if you have an adult female? You can occasionally have chronic diarrhea, sometimes with blood, sometimes without. It's more known for its association with iron deficiency. You can get anti-tissue transglutaminase positive on labs. Dermatitis herpetiformis is a known complication, and you need to restrict gluten as the treatment. So now we're describing celiac disease. What if you have a newborn or child with failure to thrive? Again, you have that anti-tissue transglutaminase positivity, and gluten restriction is recommended. So it's not a trick question. I mean, I guess maybe it is kind of a trick question. This one's also celiac disease. I just wanted to let you know they usually present it on a test in this first case, but don't forget about this newborn or child with failure to thrive. As long as this lab value is shown, that should lead you to celiac regardless. And so here we go. You'll see diarrhea occasionally in the presentation. Now what if you had osmotic diarrhea after attending a pizza and ice cream social? So that's discussing lactose intolerance. How about if you had osmotic diarrhea in somebody who consumes dairy products after recovering from gastroenteritis? And again, that's describing lactose intolerance. And I go into more detail about lactose intolerance in the small intestine lecture. Just wanted to point out those two different presentations, either after consuming dairy products in general or more acutely consuming dairy products after GI illness in somebody who had no pre-existing intolerance before. And the last thing I want to mention on this slide is if you know the mechanism by which consuming high sugar meals after gastroenteritis would cause worsening diarrhea. And so this can happen because we have a special enzyme called our sodium glucose linked transporter, SGLT1. And what this does, as the name implies, it will absorb glucose along with sodium. And so if you only consume glucose without any sodium, a lot of that glucose gets stuck in the lumen and causes an osmotic diarrhea. So this is from our small intestine lecture, and I point out that several of these monosaccharides use this SGLT1, and you need, for every glucose or galactose that enters, you need a sodium to enter as well. And that's why when you're rehydrating, you should give equal concentrations of sodium and glucose. And if you don't do that, if you just give them a bunch of glucose, a lot of that glucose will just stay in the lumen because you have a relative sodium deficiency in the lumen, and this will cause an osmotic diarrhea. Okay, so let's move on. What if you saw somebody with chronic diarrhea and somebody who recently visited the tropics and at that time developed an infectious diarrhea? It has an association with folate and B12 deficiency and can be treated with antibiotics. So that's discussing tropical sprue. And here we go. You can just remember that they have to mention some sort of visit to the tropics and some sort of infectious diarrhea. If they don't mention those two things, I would be very skeptical in picking tropical sprue. What if somebody had diarrhea, B12 deficiency? This disease is associated with PPI use and response to antibiotics. Kind of a tougher question. I talk about it when I talk about the Schilling test. This is also something you can do a Schilling test on. This is small intestinal bacterial overgrowth, or SIBO. And again, one of the symptoms of SIBO is that diarrhea. How about if somebody had cardiac symptoms, joint pains, neurologic symptoms, diarrhea, and then if you actually did a biopsy, you'd find PAS positive macrophages in the lamina propria. Now we're describing Whipple disease. And here's from Whipple disease. My favorite mnemonic is for Whipple disease is the can of whip pass. So you have the can here, talking about cardiac arthralgias and neurologic symptoms. You have, because you're sitting on the can a lot, you'll have diarrhea as well. And then the whip will remind you of Whipple's disease. And then the PAS will remind you of that periodic acid shift positive foamy macrophages. And I talk about this in the liver section, what this periodic acid shift does. All it does is it measures complex compounds inside of your cells. So it can measure glycogen, it can measure glycoproteins, glycolipids. In the case of Whipple disease, it's measuring all the glycolipids that get stuck inside your intestines. And then we'll see later on in a disease called alpha-1 antitrypsin deficiency, these PAS actually measures all the glycoproteins, all these misfolded alpha-1 antitrypsin proteins that get stuck in your liver cells. And moving on, so what if you had diarrhea and steatorrhea? You have a failure to thrive. It's caused by deficient ApoB48 and ApoB100 protein production. and you'll end up with these lipid bubbles inside of enterocytes. Now we're talking about A beta lipoproteinemia. And from our small intestine lecture, just wanted to jog your memory about how steatorrhea, or that fatty diarrhea, is one of the main symptoms that you're going to see. And you'll also they'll probably mention this sort of lipid bubbles inside enterocytes if they want you to pick this disease. And what if you found somebody who has diarrhea or fatty diarrhea in a patient with cystic fibrosis or chronic pancreatitis, pancreatic cancer, or somebody who had pancreatic surgery? Your D-xylose absorption test would be normal in this disease. So now we're talking about pancreatic insufficiency. And again, fat malabsorption and steatorrhea, very common presentation of pancreatic insufficiency, and they will definitely give you one of these risk factors if they want you to go after this. Let's talk a little bit about some neuroendocrine tumors that can cause chronic diarrhea. So what neuroendocrine tumor will cause bronchospasm, flushing, diarrhea, and right heart symptoms? And it's diagnosed with a urine 5-HIAA level. So now we're talking about carcinoid syndrome. And here's our BFDR mnemonic that we use. And the diarrhea, so it's a secretory diarrhea, which means you'll have a decreased stool osmolar gap because everything's just being thrown into the lumen, including sodium and potassium. Keep in mind that elevated 5-HIAA level, they really love to test that in the urine. And this is from our small intestine lecture. The reason why that's so high is that once it's able to be metabolized in either your liver or your lungs, it'll be metabolized into this 5-HIAA compound, which ultimately gets excreted. So you can measure that in the urine. How about a neuroendocrine tumor that causes watery diarrhea, hypokalemia, and achlorhydria? That is a vipoma. We talk about this later in the pancreas section, this classic WDHA syndrome. So this tumor overproduces VIP, and it classically causes this watery diarrhea. And that's what if you've ever seen a textbook, almost every resource uses this WDHA syndrome for this watery diarrhea, hypokalemia, and achlorhydria. I don't really like this mnemonic as much. I like this. My mnemonic here is this vipoma is very important potty syndrome, because if you're having watery diarrhea and you're having significant vomiting, honestly, the only thing that would matter to you is this bathroom. And that helps me remember it's diarrhea. I go over this in the pancreas lecture, that anything with severe vomiting would cause hypokalemia and achlorhydria. So take a look at that. But just know for now, vipoma is associated with watery diarrhea, hypokalemia, achlorhydria. How about a neuroendocrine tumor that causes distal duodenal ulcers or proximal jejunal ulcers? It can sometimes cause chronic diarrhea. You diagnose it via the secretin stimulation test. So that's a gastrinoma, also known as Zollinger-Ellison syndrome, which we've talked about in the past. Just know these ulcers in the distal duodenum, and know that the secretin stimulation test can help ascertain a diagnosis. The diarrhea on that one is a little bit more rare than most of the other tumors. These other two, for sure, as part of their classic symptomatology, will see diarrhea. This one, I'd more pay attention to the ulcers. They might give you the diarrhea, but this one's less important regarding the diarrhea specifically. How about this neuroendocrine tumor that causes diarrhea, necrolytic migratory erythema? They love that phrasing. Diabetes, declining weight, DVT, and depression. So this is the glucagonoma, which I also discussed in the pancreas lecture coming up later on. And there's the diarrhea. And honestly, on a test, if you ever see this necrolytic migratory erythema, strongly consider picking glucagonoma. All right. And what if you see somebody who has postprandial diarrhea and they get facial flushing after consuming large sugar-filled servings in somebody who had a recent gastrectomy or some gastrectomy in the past? So that's describing dumping syndrome, which we've already talked about. And all I want to mention here, I don't want to go over the entire pathogenesis, but basically you have so much solute here rushing into your intestines, and that'll form an osmotic diarrhea. So you'll get excessive diarrhea, and that's why you have to eat in smaller portions to avoid that. There's a vitamin deficiency that's classically associated with the 3Ds, dermatitis, dementia, and death, and that's niacin deficiency or vitamin B3. How about if somebody, these last two are pretty rare. I just put them in there just to be comprehensive. I don't really think you'll get tested on this too much, but what if somebody has recurrent gastroenteritis, sinusitis, otitis media, pneumonia? If there's an association with several autoimmune disorders, asthma, transfusion hypersensitivity. I think this is also associated with like false positive pregnancy tests, kind of random. This is actually IgA deficiency. And last one here, if you have a female who has palpitations, anxiety, heat intolerance, diarrhea, and a palpable neck mass, this might be tested. So this is hyperthyroidism. Let's go over some medications that might cause chronic diarrhea before we move on. So which antibiotics can cause it? Because you're altering your GI gut flora, pretty much any antibiotic could cause diarrhea. They like clindamycin and cephalosporins especially, and they like clindamycin for C. diff infection as well, as we saw. Actually, they like both of these for C. diff technically as well. Which gout medication is responsible for diarrhea? The microtubule inhibitor, that's colchicine. Which antacid has a strong association with diarrhea? Now we're talking about magnesium hydroxide. And from our stomach lecture, I mentioned that magnesium hydroxide causes diarrhea, and our mnemonic to remember that is that magnesium causes megafeces. You could also use aluminum hydroxide as an antacid, and that'll have the opposite effect. And our mnemonic is aluminum causes minimum feces or constipation. There's a few different classes of cholesterol meds that can cause diarrhea. The main ones that they want you to know are bile acid resins, ezetimibe, and fibrates. Bile acid resins we've talked about before in the small intestine and the colon section. So notice here that bile acid resins, their job is to bind to these bile acids and inhibit their reabsorption. And so if you're losing a lot of this bile acid, then you can get a fatty. If you don't have any more bile salts, what'll happen is that future fat globules will not be able to be broken down, and instead they'll be excreted in the stool, so you get a fatty steatorrhea. You also are at higher risk with bile acid resins because you're losing your bile salt. You're at a higher risk of developing gallstones. I talk all about gallstones in the hepatobiliary lecture later on. What's the first line diabetes medication, and it has an association with lactic acidosis? That's metformin. How about the other diabetes medications? This one will inhibit carbohydrate breakdown into monosaccharides in your GI tract. These are your alpha glucosidase inhibitors, very, very well known to cause flatulence, bloating, diarrhea. The names, you can get acarbose or miglatol are two of the most common alpha glucosidase inhibitors. And finally, if you have diarrhea in a woman who has a high PHQ-9 score, has tried counseling and that didn't work, so you can give her an antidepressant. And so SSRIs, very, very commonly associated with a wide variety of GI side effects. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.